All right. Hello. Hello and welcome everyone as you are coming in. My name is Jada Shapiro. I am founder of Boober. We have Dr. Sneha Gazi here today. I'm going to tell you more about both of us in a moment, but while you're coming in, would love to just drop into the chat for us. Let us know how pregnant you are or postpartum, or are you a birth worker? Tell us a little bit about yourself and tell us where you live. We love to see where people are coming in from and what's going on with everybody. So, and that way I also know that you can hear me. That's my extra bonus. So if somebody wants to go ahead, yeah, right, and drop into the chat, either how pregnant or postpartum. 33 weeks in South Carolina, 29 weeks in Minnesota. Welcome. Thank you guys. So nice to have you here. Anybody else out there? Hey, Melissa from New Jersey. Ah, I know you. I'm going to talk to you soon. I'm a birth and postpartum doula. Welcome. Fantastic. Hey, San Francisco, 31 weeks, 25 weeks in LA, where I am from. 18 weeks in New Jersey, 33 weeks in Portland. I love it. We're from everywhere. This is what's so fun, is to see where everybody is from and get a little bit of a connection so that you all feel, even while you're on the screen, 31 weeks pregnant with twins in Brooklyn. Fantastic. So we all get to feel like we're doing something here today together, right? Welcome, 15 weeks in New York City. Awesome. I'll just launch a little poll also. That way we get a little more detailed sense of where you guys are in your pregnancy or postpartum. Oh, I forgot to put birth worker on there. So while we're just letting the last people kind of come in, and then we'll get started in just a second. I'm going to go ahead and thank you. So we've got a few people 19 weeks or under, a couple that are 20 to 25 weeks. So more people are in the 26 to 35 week space, as we're seeing in the chat. Thank you so much, everyone. All right. So I think we're going to get started. My name is Jada Shapiro. I'm the founder of Boober. Boober is a platform where expectant parents and new families can find all of their pregnancy to postpartum care providers, such as birth doulas, postpartum doulas, lactation consultants, mental health therapists, adding in pelvic floor therapy, nutrition, all sorts of different things coming your way. We also provide fantastic classes, which are live, virtual, and interactive, so that we can work with you wherever you are. Of course, we were all in person until before the pandemic, but rapidly shifted into virtual care. We're back in person in the New York City area in some cases when it feels safe and okay, but we can really support all of you, wherever you may be. I'm excited today to have Dr. Sneha Gazi here. Dr. Gazi is a graduate of Columbia University's Doctor of Physical Therapy program. She has worked with New York City's leading Broadway artists and across the world with New Zealand's sports teams. She specializes in treating all forms of TMJ and pelvic health issues, and she particularly loves working with pre and postpartum moms, parents, back and pelvic pain. And so we are just really excited to have you here. I think, talking about pelvic floor, which is such a mystery to Americans, not necessarily to everybody else, but tell us a little bit about your work, how you got into this work, and what you do.
Sure. Well, firstly, thank you so much to Jada and to everybody else who's here today on the webinar. I really appreciate all the interest around pelvic floor PT because it's like, it's so important. And I'm glad that we're able to really talk about it today and answer questions as we go along. And congrats to everyone who said that they're pregnant right now. That's amazing. You guys are all like superhumans during COVID. Being pregnant and being mothers and parents is just, I know it's been, my patients just tell me all of the fears and like the added emotions. And so I think it's so great that you guys are here and showing up and ready to learn. And that's amazing. So thank you guys. So as Jada said, my name is Dr. Sneha Gazi. I am a physical therapist. I consider myself an orthopedic physical therapist who specializes in pelvic floor physical therapy. And so what that means is basically you see physical therapists for various different things, right? Like those traditional things that you'll think about, like lower back pain, probably one of the most common. I sprained my ankle, I have a frozen shoulder, I have neck pain, I have, like a tennis elbow, something like that. So you always think of physical therapists helping in those spaces. And so one part of the body that often gets missed by a lot of PTs and often gets underdiagnosed as well is pelvic floor dysfunction. So my specialty is looking at the whole body and how that interacts with the pelvis. And the reason why I'm so passionate about it is because it's really hard to talk about, right? Because the pelvis is an intimate area. You have your reproductive organs. It's sometimes like kind of a topic. So excuse me in advance today if I just like say the words that need to be said, like vaginal canal and rectum.
Here we are.
Here we are. Like, this is just what it is. So I think that the reason why I'm extra passionate about that is it's a taboo subject. And then the added layer is the intricacies of healthcare professionals maybe not addressing that part of your body, especially for parents, people who are delivering babies. Like a lot of you who are on this call, this area is so important and gets overlooked, even though it's connected to everything. So the way that I always think about it is, if you're going in to see a physical therapist, like I treat tons of like jaw pain and neck pain and things like that. And so I always look at what's going on all around your body, right? So if you go in to see a physical therapist and they're assessing your jaw, but they're not looking at your neck, then you're missing a big piece of that puzzle. And the pelvis is the center, right? Like of your everything, center of your body from top down and from side to side. And so it's connected to your back. It's actually part of your back, really, in a lot of sense. It's part of your hip bone and hip joint. And so it's just so important to look at everything holistically and look at the whole body instead of like isolating pieces. So that's why I love the subject. I think it's so great that we're here talking about it. And a lot of what I'll probably share might be like something that if it's confusing, I'm happy for people to also type in your like, I don't like, what is that word? Or I don't know what that means. I'll try my best to say everything and explain all of those terms. But if something doesn't make sense, please just tell me and I'll
Yes, and I forgot to tell everybody, actually, we always welcome, this is for you guys, so please ask questions. If it's about something we're talking about right away, you can just drop it into the chat. If it's something that you want to park for later, it's a topic that, you know, we're either going to get to or not, then just drop it into the Q&A in the bottom and I'll be fielding those questions out after. So can we start a little bit with, you know, I think, can you just truly describe, actually, I'm gonna shift out what I'm saying. So many people who know about pelvic floor therapy, which is not everybody, so we're gonna talk about that, but a lot of people think about it as something after childbirth. And I'd love to bring us back into pregnancy first. Like, would you recommend that the average person look into physical, you know, pelvic floor therapy when they're pregnant? Or what is a reason somebody would come in when they are pregnant or want to see somebody virtually?
love that question. So you have a pelvis before you're pregnant, while you're pregnant, and after you're pregnant, right? Hopefully. So the way that I see this is prevention tops everything. It's sort of like what you might say, Jada, as a lactation specialist, or doulas who are on the call might say also, or you also would say to a mother or parent about their birthing experience. You teach the things beforehand so that you can prevent a lot of unwanted, you know, things that could potentially go wrong or not go as expected during the birth, right? So in that sense, I always tell people learning about your pelvic floor, understanding how to use the pelvic floor correctly and when to identify signs of dysfunction, which is something we're going to do today as well, more in detail, is so key before you're pregnant and at the latest while you're pregnant. That's like the latest, right? Because, or what I would hope is the latest. What ends up happening is that people postpartum tend to find that there's an issue or something is a little off. And then two things happen is one, they either don't seek care completely because they don't know. Their healthcare provider, who's their direct line, doesn't know to refer them, or the patient doesn't know to seek service because it just doesn't exist, or there's no communication, or it can happen too late. And so the person has been struggling for a little while when it was probably in essence something that either could have been avoided or simple changes that could have helped that person overcome some of that struggle. The second layer of difficulty is postpartum. You have a thing to keep alive, right? So oftentimes what I'll find is that and these are a lot of my patients who I treat either before their pregnancy or while they're pregnant. And so after pregnancy, things can still come up. But what always happens without fail is that they're able to implement and overcome and push forward through that with a lot more clarity, confidence, knowledge, and the tools. They have all the tools. It's just an implementation program at that point. So they've set themselves up for success. Similar to how you might learn about the stages of labor before going into labor, or similar to how you might learn about colostrum or breastfeeding or certain techniques of how to do this and that before actually being in that moment, like, oh my God, what do I do?
Well, I think so much, people when they're pregnant, they hear the word Kegels. I'm sure everybody out here has probably heard it. And even maybe practicing it, and I think even in some childbirth education, they might be saying, do your Kegels, do your Kegels, do your Kegels, right? And then we know that there's this issue of A, are we teaching people to do Kegels correctly? B, should, a Kegel, my understanding is there's this coming in, but are we releasing? I would love for you to explain more about that issue, because can you address a little bit, like we hear from pelvic floor therapists all the time, and I've recently discovered this myself, so I want to talk about it a little bit, that many of us are actually much more, we're tighter than right? We're not having the opposite problem. And therefore that can impact pushing and all sorts of things. So I would just love to maybe start with the Kegel. What is that? Should people be doing it? Should they not? Is it on an individual basis?
Great.
So many things I just asked.
No, I love that question. And I might go off on a tangent. So if I do, you can.
Yeah, I mean, that's fine. I just gave you like 95 questions. So.
Okay. So for this, I'm actually going to explain what the pelvic floor is before we go into what is a Kegel, because I think that's really the good way to look at it. Okay. So orienting everybody really quickly. This is a model of a pelvis. This here is your pubic bone. At the front here. And this is what people call the pubic symphysis, that joining of the two sides of the pubic bone. This is like where, if you were to put your hands on like the top of your hip, that's where that is at the top. And then at the back here, this is your lumbar spine, like the end vertebrae of your lumbar spine, your low back area. And then this is your sacrum. And this is your tailbone. It's super tiny, a tiny little tailbone. Okay. And then I'm going to flip this way. And I'm going to show you guys these two. Like, this is like if I was to lay back, right? So that's the pelvis is laying back like this. These are your sit bones. And then you can see that this is like a bowl, right? And I'm going to take out my fallopian tubes. I'm going to take out my rectum and my bladder and my uterus and all those fun things. They're all sitting up and in this area on top, right? And I know this is probably like super basic for most people, but the point is to say that all these things that you see in red, all of this like the striped red stuff that you see. Oh, and by the way, this is your vaginal opening. This is your rectal opening. This is female anatomy. So everything that you see in red, all of this stuff here, they're all muscles. So they're muscles similar to certain muscles in your body, like your glutes, your biceps, your hamstrings, the muscles that make my hand go like this, and the muscles that keep my mouth moving. They're called skeletal muscles. Skeletal muscles are ones that you can voluntarily move and control. So your central nervous system is controlling these muscles. It's what gets us to do things in our life. But then you also have like cardiac muscle and other smooth muscle, things that you can't control. Like you can't control your heart rate. You can't tell your heart how many beats a minute to beat. You can't tell like your smooth muscle in your stomach, like go from stomach to small intestine. You can't like tell it to do those things, right? So you have different types of muscles, but this particular type of muscle here, this is called your pelvic floor muscles. There are different layers to them. They have all these fun Latin names, but that doesn't matter. The important part is where they are. So you can see from sit bone to sit bone around your vaginal and rectal openings, from your tailbone all the way up towards your pubic bone. So this is pretty much like, it's like a bowl that's supporting, it's three functions. It's supporting everything. Well, four functions, sorry. Supporting head, arms, and trunk, the weight of your pregnant belly, the weight of your baby, all of the stuff that's on top, supporting that. So it's like a trampoline. These muscles, the connective tissue, all the stuff that's here, the skin, the fat, everything is like a trampoline that's holding up nice and taut you standing on top of the trampoline. And it's elastic, okay? The other functions are bowel, bladder, and sexual function. obviously, you got your urethra controlling your bladder, bowels here, and your sexual function with reproduction and childbirth, right? So all of these functions, the muscles, the connective tissue, these little white things are like ligaments. They're basically just like tight ropes that like hold things in your, like one side of the bone to the other side of the bone are just held together. They're just all structural support systems that control everything. So when we talk about, now going to the Kegel, this is why this is important. A Kegel, the definition of that is a contraction of these pelvic floor muscles all around here. From here to here and here to here, everything that you see in red, squeezing shut, lifting up. It's a two-part thing. Squeezing and lifting is a Kegel, okay? It's commonly confused with clenching your butt, commonly confused with tightening your inner thighs. When you do a Kegel, there's actually no movement of the bones in your body in a way that you can see it if you were to sit. So if you do a Kegel and you're actually like crunching, or if you do a Kegel and your knees come together, or if you do a Kegel and your butt lifts up, those are all indications that there's so many other muscles that are you're contracting and you're not actually doing it. Kegel, that for what it's worth. The second part of this is that there's also something called a reverse Kegel, for lack of a better word, which is the relaxation part of the Kegel. So the contraction part, so squeezing and lifting. So I'm going to use my biceps as an example, right? So this is my bicep, okay? So this is, if this is my neutral, like this is my hangout position, just pretend like this is my neutral position. A Kegel is a contraction. So I'm flexing my bicep, I'm doing a bicep curl. I am contracting this muscle by bringing my wrist closer towards my shoulder, okay? That's the Kegel phase. Now a reverse Kegel, in a metaphor here, is me going like this. Okay, me opening and me letting go, this phase of it. So you're absolutely right, Jada, that most of us are taught in the media, in all the things, to do this, over, which there is nothing wrong with doing the Kegel. It's just that as equally as it is important to do a bicep curl and have strong biceps, we also need to learn how to let go of that muscle and stretch that muscle, because that's what's creating your full range of motion, to be able to keep that muscle functional and to keep the movement be functional too, right? So for this example, right, functionally, I need to be able to do this to wash my hair, put food in my mouth, whatever, right? But I also need to do this to reach for the top cabinet. I also need to be able to do this to push a cart or whatever. I need this motion in my life as well. So similarly, now let's bring the pelvic floor with what I said about the functions of the pelvic floor, right? So we talked about bowel, bladder, sexual function, support, and all that stuff. So obviously you want it to be strong because it's supporting some of the most important vital organs. Head, arms, and trunk, that includes your lungs and your heart and all of the weight that's coming down. So you want to make sure that this area is strong for that reason. You also want to make sure that you have stability and strength for keeping you continent, right? So what's continence is the ability to control your bowel and bladder and be able to go to the bathroom when it's time to go to the bathroom, and not have lack of control and have to pee or have to poo unwillingly when that's not the right time. That's not the right time for you, right? So for those reasons, also you need strength. You need to be able to hold. And then for pregnancy, of course you need stability, because you've got more additional weight of your body and the baby's body on top of the pelvic floor. So again, you need to make sure during childbirth that you have stability, so that during pregnancy, postpartum, you reduce your incidence of a pelvic organ prolapse, which is basically when any of the organs that I pulled out of here could descend downward to different types of degrees because of lack of that trampoline's not tight enough. There's too much weight on top or too much pressure, and you need strength for that. But then you also need things to come out, right? At the same time as you need to hold things in, you also need to have lengthened your pelvic floor enough to be able to have a bowel movement. You need to be able to open this muscle to have a proper bowel movement and not be constipated, for example. And then the biggest reason why everybody's here, if you're having vaginal childbirth, that baby's got to get out of somewhere, right? So we need to be able to lengthen and open and allow something to come out. The one other thing that I'll say for letting something come out is also allowing something to come in. So this is penetration. This is intercourse. A lot of my patients, like you mentioned, Jada, are really tight and hyper tight. They're clenching. They're always doing the Kegel phase of everything. They're not opening because something can also need to come in. That's functional as well. That's required for people as well, right? So having something to come, the ability to have something come in or out requires the lengthening phase. And we also need to make sure that we're supporting. So that's, I guess, the best way and the best analogies that I can use for why it's important to be able to do a Kegel, but why it's equally, if not right now in your pregnancy, even more important to understand opening and letting go if you're having, especially for a vaginal delivery. So that's in a nutshell. I could keep going on and on, but I guess I'll stop for a second. You're muted.
Thanks. So if you were to work with somebody prenatally to help them understand that release and strengthening and all of that, I guess I would love to hear a little bit about how you do work with people. I know you do in-home visiting currently in a COVID safe way, but you also obviously, like everybody, turned into major telehealth during this time, right? So could you talk a little bit about how you can help somebody, especially actually virtually, because I think that's an issue for a lot of people right now, but also in person, how you actually work with them?
Sure. Yeah. So studies show that one of the best ways to learn pelvic floor function, which includes understanding this whole concept of doing the Kegel and reverse Kegel, one of the best ways to do it is actually to have one-on-one coaching for it. Studies show that just listening to something may not be the best way for somebody to learn. For some people, they're auditory listeners, so that's just the way that they're going to learn. But one-on-one help is really one of the best ways to know that you're actually doing it correctly. So how would I teach that to somebody in their home? There are a couple of different things. Firstly, just like I'm doing for all of you guys, I explain this because knowledge of what is this thing that's happening in the first place, visualizing it on a model, and then visualizing it on yourself can be the first step to gaining awareness. Because again, going back to what I said before, it can be a little hush taboo. I don't want to, I have $1 for everybody who said, I don't want to look at that. I don't want to touch it. I don't want to see it. So becoming in tune with your body and understanding it and being able to visualize it is important. So what do I mean by that? So during my in-home visits, one of the things that I might do with a patient, this is all with them being educated, having consent and understanding what's going on in a very safe environment, is to show them visually, either with like selfie mode on their camera or a handheld mirror with themselves, what is this contraction and relaxation look like on you? Can you see that there's movement in the pelvic floor? When I say do a Kegel, what happens? Does your butt lift? Are you actually doing a glute? Are you squeezing your butt cheeks? What's happening in that area, right? So that's step one, is to be able to hear and understand everything and then to visualize and see it. And then if the patient is comfortable with that, what's very common practice in pelvic floor physical therapy is to do an external and or internal evaluation, where the practitioner or myself will see if the patient is squeezing these muscles by actually physically touching them. So if everybody right now press really hard on your bicep muscle, right? Like really hard. So you can like really feel it, like squeeze and pinch that muscle. And then go ahead and make a big fist. And you would have noticed when you made that big fist and when you're squeezing the muscle, you can feel that muscle contracting, right? You can sort of like sense with under your fingertips that this muscle is moving, that it's the fibers are shortening. You can feel it lifting, right? So similarly, they're the same kind of muscles. They're the skeletal muscles that are just like our glutes, our quads, all the other ones in our body, right? Same thing with your jaw. So if you put your fingertips right on the edge of your jaw and then go ahead and clench your teeth, you feel that muscle popping into your fingertips the way that it should when it's contracting, right? You're using the muscle so you can feel that the muscle is tightening around your fingertips. So similarly, you can actually feel around this area to see, are we squeezing all of the parts of the pelvic floor muscles, all of the layers, all of the types of different pelvic, all those different Latin words, are we contracting all of them equally from side to side, from layer to layer, from muscle to muscle? And then is it painful? Is it painful to do that? Are you compensating by doing something different? Are you actually squeezing when I'm telling you to let go and letting go when I'm telling you to squeeze? Are you holding your breath
right
when you're doing this? Right. So I'm assessing all of that when I'm doing an external or intravaginal or intrarectal assessment for the person. So I'm checking to see, is that squeeze happening? Then is that release happening as well? So are you able to open and let go and really do the opposite of that, which should be the lengthening phase of full range of motion of your Kegel? So that's how I would teach somebody in person. It's usually step one. And coordinating this, there's a lot more to it. It's a little bit more complicated, but you have to coordinate this with your breath, with your core unit, with everything. And so that all of those different parts get taught and the patient will understand why they're even important. And the best part is that I think that 99.9% of the time, when somebody learns this and gets it right on the first session, they'll go, wow, I've been doing that wrong.
I mean, it blew my mind. So I have a 13-year-old. I didn't do my first pelvic floor therapy visit until last year. It was actually, I remember laying on the table, listening to everybody talking about whether COVID was going to be a thing or not. So I guess this was right before it was happening when I was there. And I went in finally. I actually want to talk about symptoms, like why should people go in? Because I, like, for the last couple of years, was like, had to pee all the time and kind of ignored it for a while and like kind of, did my thing. And finally, obviously I've been in this field for a long time and I know a lot about pelvic floor therapy, but sort of like pushed it aside and was like, maybe this is just me getting older and like having to deal, just like kind of, and finally, I was like, wait a minute, this is what I do for a living. And I talk to people about it. I really need to go understand and learn for myself. And it blew my mind, like having the physical therapist fingers, she did put her fingers inside me. And I realized how tight I was. I had this band of area inside that was really quite tense and painful. And I didn't realize that even. And when I learned to relax in that specific spot, it was amazing how all of a sudden I did not have to pee all the time anymore. I mean, a couple sessions, it didn't take very long to retrain. Yeah. And so I'm sharing that all with you guys because it really, really was life-changing. And I wish that I don't think I should have waited 12 years after childbirth. Like, so I would love to just share that. So what symptoms do people often, like what brings them in? If somebody's pregnant, what might bring them in if we're going symptomatic? And of course, we also want to encourage people to be preventative, right?
Yes, absolutely. Well, before we jump into that, I'm going to do the telehealth bit because I missed that.
Yeah.
So with telehealth, because a lot of everything is virtually, this still works and actually, I'm going to say it almost works better. Because the patient actually has to develop so much more self-awareness of what they're feeling. And they have to be like so focused and in tune with their own bodies as I'm guiding them through this self-assessment, that it's like, boom, like it's almost as if it's like this lightning bolt just like strikes through them. They're like, wow, that makes so much sense because I'm doing this on myself or for myself. So that would require similar stuff that we just talked about. So you could see with the mirror, they're going to do a self-assessment. We just turn the camera off when they're doing this. We can just go through this vocally, but they're giving me feedback and I'm showing them with the model what's happening to them or what they should be doing. And so I'm able to take on and discharge patients virtually through this assessment as well, depending on what their complaint is, whether it's I'm coming to you because I'm leaking urine or whether I have just a painful intercourse or whether it's constipated or any of the million things which we'll get into right now. So virtual does work. And it also, I think it allows a lot more people in areas that otherwise wouldn't have pelvic floor PT. Like I'm licensed in 3 states, in New York, Maryland, and New Jersey. So for those folks that I wouldn't have been able to see in upstate New York, for example, and they don't have a pelvic floor therapist who's near them because they're more remote of a location, they're actually able to gain access in a way that was just not possible before that. So I think that's the really powerful and cool thing about it. So I encourage everybody to look into it, even if you think that it would only be beneficial in person or in a clinic. There's actually so much that you can gain from education and self-awareness when you're doing all of this telehealth or virtually. So that's that. Having said that, okay, so we're coming into symptoms, and your question is, why would somebody know that they need to get pelvic floor PT? Okay, so there are like an umpteen number of diagnoses and sort of what we call pelvic floor dysfunction, which is basically when something is off, like you don't like something, it's not the way that it should be working, and you have any kind of a symptom. We just call that as pelvic floor dysfunction as a blanket term, but within that, you've got multiple different things that could go wrong. So, and there's multiple different ways to categorize this, but I'm going to go by what you mentioned, which is just symptoms, because that's what everybody's looking for, right? Like when you feel something as a symptom within your own body, that's what's going to be the easiest for you guys to understand when to get help or that something is off. So firstly, we should never have pain in and around the pelvis, in and around the back, the hip joint, or anywhere, right? Pain is an indication either with acute pain that there's actual tissue dysfunction, like something is going on with the bones, the muscles, the ligaments, the connective tissue, that something is off. That's with acute pain. And then there's also chronic pain. So this is pain that's been going on in different places, I'll say either longer than 3 months or longer than 6 months. And it's just like keeps on going and going and going and really doesn't stop. And that's chronic pain. And usually chronic pain is oftentimes in the absence of tissue damage. It's when there's something that happened to the system that wasn't resolved in here in the nervous system. So the brain, the nerves connecting down into that area. This could be anywhere. This is the same format, whether we're talking about neck pain or chronic back pain or chronic knee pain. There's been a nervous system disruption. And so potentially in the absence of there actually being a laceration or cut or a bruise or a bump or anything like that, we're still actually experiencing pain that's real. The receptors are still in your body, are still experiencing that pain signal. And that's also a sign of dysfunction. So whether it's an acute, like, ow, 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 like sort of a pain of I stubbed my toe, or like the dull ache you get when you bump into something, like those kinds of pains, or whether this is something that's going on for a long time, that's still considered that there's something off with the system, an indication to come seek help. So that's one thing. So pain anywhere. So I'm going to just go through locations that I commonly find people getting pain, especially in this pregnancy population. So the pubic symphysis. With the hormone relaxin, things are moving around, you're getting more loosey-goosey. The hormone is just letting your body make room for the baby and expand for the baby. That's what's necessary to happen. But the hormone goes in your body systemically all over, right? So often what can happen is a pubic symphysis, this little cartilagey thing here, can get a little loosey-goosey, and it could create just like a mismatch between the two sides of this pubic bone, or just pain there, even if there's no mismatch. It's a pain. It just gets, for lack of a better word, wobbly. Okay. Yeah. So that's a common site at the pubic symphysis. So just right at the top of your pubic bone, people will often complain of like a sharp shooting pain, or just like when they're going up and down, like in a transitional movement, like sit to stand, rolling over, laying on their belly, like certain movements like that can be painful. There are a lot more things that could cause that pain and movement wise, but that's the spot. Okay. The next one is what people might have heard, the SIJ or the sacroiliac joint. All those fancy words is just for this area right here, here and here. So that's just fancy for, this is the sacrum and this is the ilium and this is a sacroiliac joint, this little part that's in between joining your hip bones to your spine. Okay. So this is, if you guys can tell, like this is and this is to scale-ish for a human. So this is your tailbone and this is your sacrum right on top of that. So if you found your tailbone, which actually starts basically like where basically your butt crack starts, right above that, if you were to put a fist, if you were to make a fist and put your hand there, that's actually your sacrum, right? So if you go right off to the side of that and maybe a little up and down, that's the location of your sacroiliac joint. So that pain is often confused with lumbar spine pain. That's like up higher. That's a little bit further up. Of course, again, another one, a common thing, reason to see a pelvic floor PT during pregnancy or postpartum, of course, that low back pain that's a little bit higher than the SI joint. So those are some of the immediate pain locations. Same thing. This is the socket for your hip bone to come out of. You see how close that is, right, to your pelvic floor muscles here. And it's actually, you can't really quite see it in this, but I'll show you. Yeah. So that hole right there, that's right next to this area. And everything inside is your pelvic floor muscle that you see in the red. It's a bowl, right? So it kind of lines the pelvic floor muscles and your pelvic floor structures line that inside of the hip joint. So hip pain is another reason. So what are we talking about? Pubic symphysis, the low back, your hips, and really anything else that's pain around this area can be, and oftentimes people will complain of labial pain, or pain that's like in between their two openings, right? So all of those things are reasons to seek help from a pain perspective. And then from a non-pain perspective, people might complain of constipation or fecal incontinence. So that's when there's something going on with this guy here, right? So are we able to control our stool from coming out when it's the right time? And also, are we able to let go and open when it is time? Of course, constipation has multiple other reasons. You could have celiac disease, you could have IBS, you could have a nutritional issue. It could, all of those things. But I'm talking about like chronic constipation. Like this is not a one night thing and I just had really bad dinner sort of a situation, right? So constipation can be a reason to see a pelvic floor physical therapist. Urinary dysfunction. So there's a lot of different things within the urinary system. So it could be the thing that we often hear about, which is what Jada, you went to pelvic PT for, which is a constant urinary frequency, urgency, or incontinence, where you're just peeing a lot. You have a lot of urgency to pee, even though you don't pee much, or you leak when you pee. And that could be because you coughed, that could be because you ran, or that could just be like suddenly you have to pee, you just can't make it to the bathroom, you pee yourself, right? So all of those peeing problems that we kind of think of, they're all signs of dysfunction. And while people might tell you they're common, yeah, they are very common, but they're not normal. They shouldn't be happening. It's dysfunction in the system and it can be rehabilitated. It can be treated as such, right? So that's some of the urinary things. And then reproductive stuff. So intercourse being painful, intimacy being painful, orgasm being painful, just an inability to achieve an orgasm or inability to have tolerate penetration. Those are all reasons to see a pelvic floor physical therapist. There are tons more. Like if you're experiencing, like pelvic floor PTs treat endometriosis, pelvic floor PTs treat lower abdominal discomfort that might happen either because of an IVF procedure or like a lot of different types of procedures. Pelvic floor PTs treat the scars that might happen, either C-section stuff up here or episiotomy tears. Or just natural tearing that gets sutured up. That usually happens right here in between. So all of that really sensitive scar stuff, pelvic floor PTs can treat that.
That's a great segue into that because I wanted to talk to you about it. So in places like France, we understand it's kind of considered par for the course. You see your pelvic floor therapist after you give birth is my understanding, and maybe insurance covers like 8 visits, something like that. Here you have to think of it, most OBs don't seem to mention it at all to people. It's not considered standard in any way, shape or form. So I would love to hear, when should somebody, in theory, after giving birth, like what are the things we can do on our own? When should somebody, again, seek care? Should everybody seek care no matter what in an ideal world? We would say, yeah, let me have some sessions with the PT after I give birth, or how would you approach it?
Yeah, sure. So this is like, in theory, absolutely. I think that it is just such a service to have outside of your medical checkup. So I know you guys go into your 6 weeks or, just immediately postpartum when you're in the hospital, they're going to do a medical screen. They're basically going to make sure that you're alive, that your baby's alive, right? That's obviously super, super important.
Pretty much. Yeah.
That's
it, right? That's kind of all we do.
Yes. And it's like, sure, you are alive, but are you functionally alive, right? Are you able to cope with a lot of things? So that, and this is like, I know we're not talking about this, but I think that during that medical screen, we should also have a mental health screen for sure, and a physical, very specific pelvic floor screen as well, or a biomechanical or orthopedic screen. I don't know what I would call that screen, but it's something where we're checking to make sure that this new parent is functional. Are you able to pick up your baby correctly without low back pain? Are you able to rock and feed your baby in a position that's not excruciating for you? Are you able to do some basic functional things? And then what are some things to check in your pelvic floor to make sure that it's full range of motion again, or teach people these preventative things like how to do the C-section scar massage. It's so easy, but if people could learn those things and know when to start them, I think it just sets people up for success. So to answer your question, in theory, absolutely. I wish we were like French people and I wish we could have at least one checkup, but really like 2 or 3 would be great. For every parent. And then if on that first screen, there is there's a full physical therapy evaluation, which is what I would do. I'm checking for a diastasis recti. I'm checking for a prolapse, checking for full function of your pelvic floor. I'm checking your lumbar spine. I'm checking all these things. Even if that person just came to me and said they have a little bit of leaking or a little bit of urgency postpartum, but I'm going to check all of that because they're all so connected. If during that screen, we find that there's something that's off, and coming up with a tailored plan customized to that person based on their goals and needs.
And so and what
I was going to say is just that I think the biggest barriers to this, and I know that wasn't a question you asked, but I think the biggest barriers to this is one, the education around it, which is why I'm thrilled to talk about it right now. Both from a patient's perspective and a provider's perspective. So people who are the medical care providers, the nurse practitioners, the OBs, the midwives, and then the lactation support, the doulas, all the people, right? Like all the practitioners that work in the perinatal space should know, the patients should know. And then of course there's the insurance and the compensation, all that stuff. If it was easier, we could figure that out in a seamless way for the parents.
Absolutely. So let's say somebody they hadn't done pelvic floor therapy in pregnancy. It's after about when, they've given birth. When would you normally see somebody first? When would be a good first visit for a general, not somebody with a very serious issue that they know is an issue, right? But they're saying, I want to take care of my pelvic floor health. I want to do a check-in. Like how soon would you do that after birth?
So if there's zero problem, then getting that 6 weeks medical clearance and then starting PT is great. I think still like having the I say that with a caveat of, I still think that during pregnancy, there should be that understanding of the pelvic floor with like prevention knowledge and just understanding of pelvic floor, how to use your pelvic floor during birth and all that stuff should be taught before. But if that didn't happen, then, and there's no pain and no dysfunction, and there's just self-care and management and prevention for after postpartum, later, then I think right after your 6 weeks checkup is fine.
We got a question that came in actually, which is something I wanted to ask you. So thank you for submitting this question. We want to ask you about, what are your thoughts on home pelvic floor trainers like LV, various things like that, which is a device that you can insert and squeeze, and you kind of play a video game with your vagina, and you're able to start to get some feedback. I know that you use, talk to us about the kind of machines that you use when you work with people to do that biofeedback, and does the pelvic floor trainer, is that useful for people?
Yeah, sure. Great question. So in pelvic floor physical therapy, we actually have a biofeedback unit. I didn't pull it in right next to me, so I'm just going to grab it so I can show you guys really quickly. 1 second.
I'm excited. We get to see. We'll have to do some little videos.
Sorry about that. I just want to make sure it was useful to talk about it and have it open in front of me. So a biofeedback unit, the theory behind it, biofeedback could mean anything, right? Biofeedback is also, when I talked about how you could use a handheld mirror or the iPhone on selfie mode, biofeedback is just you looking at something, getting feedback to your brain, and then implementing the knowledge. That's not me going, you can do it, do this, do that. Biofeedback is you seeing something and getting feedback from it and then implementing it into your body. So having said that, the biofeedback pelvic floor unit that PTs use, there's so many different models, and this is just one of them. This guy right here, there's a sensor that you can insert either intravaginally or intrarectally, or sensor stickers that just go like around the pelvic floor area, not in your pelvic floor, those stickers, but just go around, like around your external genitalia. And they connect to this box, and the boxes can come in a variety of different models and stuff. But in this screen here, you would see numbers. And so those numbers are basically when the intravaginal or intrarectal sensor or the sticker sensor is attached, what it's doing is it's sensing, in most simple way, the voltage of the nerve. It's like your brain telling through your nerves, fire muscle, fire, right? So that's that skeletal muscle. Like you're voluntarily, there's like a chemical response that makes me do this with my hands, that makes your pelvic floor contract and relax, right? So it's just sensing that in the simplest way, and it outputs it as a number that's just displayed here. Some people love this, and some people really don't like this. The people who love it are the people who enjoy seeing something and are visual learners and can implement that and see changes. The number, when it goes up and down, indicates whether your pelvic floor is contracting or relaxing. So the thing with this is that it's giving you an actual output of a number, whereas I don't think that all of the LV and those things give you a number. It just gives you kind of like a bar, I think, from what I understand.
It's relative to itself. Like if I'm doing stronger, it'll show me higher, but I don't know that it has an actual measurement of specific strength.
So for the people who are, if you think about this, right? So for somebody who is super tight, who has a lot of tension in their pelvic floor, and Jed, I'm going to use the example of that muscle band that you mentioned to us.
Yeah, absolutely.
Remember you said that there was like a band that you didn't really even know was really tight and painful, and that getting the release was actually helpful for you, right? So without knowing whether you're tightening in an area, continuously contracting around that tightened area can sometimes actually perpetuate the pain cycle. Sometimes it can help, and it depends on the person.
Right.
So the biofeedback, what it will do with the pelvic floor version is that we're actually going to do a symptom assessment, an objective physical assessment with our hands, and then correlate that with the response of what's going on here, so that we can determine, are you actually already super tight and you actually need to do what we call down train. You need to relax your pelvic floor. You need to chill the pelvic floor. Or is there 100% weakness here? There's no contraction. We're not getting a response, and we need to up train this guy, and we need to LV, we need to contract, right? So that's why my answer is that it depends. Do I like the LV? It completely depends. If you're in a place where there's a lot of weakness, you know how to contract your pelvic floor muscles correctly, and then you use the LV, and it's a great biofeedback way for you to be motivated, and you're like very like goal driven, you like to see the scores, that's the type of person you are, that's the best way to go. I think that's an awesome way to progress with the treatment plan. But the problem is that not everybody is at that stage. And so as a generic product, it can actually, for some people, be really detrimental to their pelvic floor health and actually do the opposite of what we want, which is why I think the pelvic floor evaluation and getting set up correctly and then doing those kinds of things is great for you.
It's really interesting. It's very similar to in lactation, right? The nipple shield could be a tool that's very useful for somebody if they have a specific issue and they know how to use it properly. But when people just go ahead and use it without any background, it can create all sorts of issues that weren't even an issue in the beginning. So it sounds like it can be a great tool, but always a great idea to get that first assessment to really be sure you are understanding how your pelvic floor works in the first place and using it with some guidance.
Absolutely. I don't know what a shield is. I need to learn about this.
Oh, the nipple. Yeah, we'll talk about it in another class. So we have a couple more questions here. Actually, I'd love to address. Somebody said, I've read some different recommendations for how many Kegels to do per day, number of Kegels per set, number of sets, how long to hold. So this is assuming somebody's been taught how to do it properly. What can you answer that question, or is it different according to everybody?
Good question. So it is a little bit different according to everybody. I have treated patients who they max out at their 5th contraction. After that, they're no longer doing a Kegel. They're doing all sorts of other things. And they think they're doing the Kegel, but they've actually maxed out. They've fatigued the muscle. So imagine like you're really doing like pretty heavy weights at the gym, right? Like you're doing a bicep curl with like 25 pounds and you've like barely ever lifted 10 pounds.
Right.
So say that you do this like big bicep curl, and the first one you do, you go like this, right? And then it's like really hard. So then the next one, you're going to go like this.
Right.
And then the next one, you're going to go like this. And you're going to do all sorts of things, and you're going to bend your body, and you're going to like try all these things to get the arm up, which is getting the arm up.
Right.
But you're not actually doing a bicep curl anymore. You're doing like shoulder shrugs and side bending and all sorts of other things to do this exercise. So to answer the question, it completely depends on the person, how many they can do. And that's why that assessment is so important to check how are you contracting. And the pelvic floor PT, what I do with everybody is actually figure out what their maxes are, both from how many contractions can you do, how many sets of those can you do, how long can you hold it, outside of just contract, relax, how long can you hold your full max contraction for how many seconds, right? That's called, there's a scoring method that PTs use to figure that out. And that's your baseline. And then we actually retest this. I actually retest it almost every session, but if I saw that person really, really soon back to back, and we're working on other things, like how we're focusing on how to pick up their baby and we're waiting on that part, I'll just check in with them the next week or then in 2 weeks, because we wait for the time for you to learn and practice at home. Because just like every muscle, it takes time to learn it, right? So it depends on where you start with. Again, I've treated patients who could do 3 sets of 15 off the gate and hold it for 30 seconds. And it's, wow, great job. There's nothing wrong with doing 5. There's nothing wrong with doing 15 or 30 either. It's just, where are you at in your journey? And then what is your goal? And why are we strengthening your pelvic floor? Are we strengthening it because you have urinary incontinence, pelvic pain, and something, and we need to rehabilitate you? Or are we doing these pelvic floor exercises because you're okay, but you only leak when you're going to run outside and your goal is to run a marathon next season? And that's what you want to do. But right now, like, you can walk around and do everything okay, you're not leaking. But then when you go for a long run, that's when you start leaking. There's a whole different protocol for athletes and runners and people who want to do different things with their bodies on how we're training that pelvic floor. So in that case, that protocol looks very different. And there's nothing wrong with that one either. Or for the mom who's just like, I just want to get out of bed pain-free and like hold my baby without feeling like everything's falling out, right? So it depends on your goals. It depends on where you're at. But I'm going to like do the thing that PTs will hate me forever for saying. And I'm just going to tell you guys that if you are in no pain, you know exactly how to contract your pelvic floor, either because you were taught to do this or you've done a self-assessment guided by a PT virtually, and like, you've got this, there's no pain, there's no dysfunction, and you're just trying to do like management, like you just want to keep your pelvic floor healthy, just like we do squats to keep our glutes and our quads healthy, and we do bicep curls to keep our arms healthy. I'd say a good number to do is 2 sets of 15, maybe 3 to 4 times a week. That's it. And the reason why I say that, and some people will hate me for saying that, is because it's personalized. But then the reason why I say that despite that is that some people think they need to do 150 an hour to stay strong. And that's overdosing. That's not good for you either.
Well, thank you. And, you know, we do lots of little snippets and teaching also about, and we'll be adding in more on pelvic floor at Get Boober. So if you guys have your cell phones and you are on Instagram, we'd love to invite you to follow us at Get Boober. And Sneha, if you want to drop your I think you feel free to do that. And we'll also talk about, you know, bringing pelvic floor now onto Boober. We're excited if anybody does need support, you can reach out through us to be connected. But we really do love to, you know, offer great information and teach. So we hope you guys will follow us both. It's a great place to get more learning. So let me ask you a couple more questions as we get to come to a close, although I feel like I could talk to you all day. So much great information in there. Somebody asked, how common is it to get pelvic pain 30 weeks in? Is there a way to minimize pain when standing up or moving, shifting positions in bed, particularly? It sounds like this person's struggling with.
Totally. So it is very common to have some pelvic pain. It also depends on where exactly that pelvic pain is, right? So this is your pelvis. And so we got different areas where you could experience pelvic pain. Some people feel like they experience it like inside, like it's really hard. It's almost like it's your cervix, somewhere up, like in your uterus, almost like period pain. And then some people might experience pelvic pain as in like in their, like right at the genitals, like right at your pelvic floor. There are obviously different statistics around these on how much it's reported, but I also think that how common is it is a really hard question to ask from a statistical perspective, period, because people don't report it. That's the problem. A lot of, especially women, will have a tough time to say that they have pelvic pain. It's taboo in a lot of cultures, even taboo in our culture, despite how open Americans are. It's still a difficult concept to bring up. So the commonness of it is only, I'm going to explain from my perspective. And I'm going to tell you from just treating patients that it is way more common than we say it is, and that it's still not normal though, that it's very common to still have that anywhere in and around your pelvis while you're pregnant. Now, is there a way to minimize the pain when standing up or moving or shifting positions in bed? So yes, there is. But again, because this question is a little bit vague on the location of the pain, and also would be best to like see how the movement is like how the pain is elicited with which movements, giving adjustments to it is actually one of the more simpler things. So I'll just give you an example. When people say often that shifting positions in bed, like turning to the sides, causes some pain, especially at that pubic symphysis and the joint in between. One thing that I suggest to people, and this is just a general example, I don't know where this the question is coming from, but a general advice or tip that I give to people is to put a pillow in between their knees that's large enough that it actually separates their knees in a way that their hips and knees are parallel, right? So keeping that neutral, I put that on quotes because everybody's neutral is a different neutral. Keeping a little bit of space and not letting the knees come together or fall apart too far can just try to like reduce that clinking, wobbling, clanking that might happen at the pubic symphysis and at the low back joints, right? So that's an example of shifting positions and trying to minimize that. And then when standing up or moving, it sort of also depends. One of the things that I'll say about standing up and moving is that a lot of people have pain either in their low backs or their pelvis because of that third trimester pregnancy position, which is oftentimes, and I'm just going to show you guys this standing up, but a lot of times what people will do is you have this belly in front of you here, right? So if you did nothing, then gravity makes you go this way, right? Like it's going to tip you forward. So in order to just physics, like just speaking from a physics perspective, in order to keep the center of your mass, which is really like here, not here anymore, but like here, over your base of support, which is your feet, people will often have to do this to do that. So you'll have to tip your body weight back so that your belly now is a little bit more over your feet. Right. And when people do that, pregnancy is like, I always akin it to all the pediatric patients that I see who have growing pains, right? Like if their shin is hurting, this is hurting. And I always tell them it's because you're growing. So we're managing and we're kind of like holding the symptoms down, and we're kind of trying to catch up. Your muscles are catching up to these, and your joints are catching up to this growing phase. Yeah. And that's similar to pregnancy. It's a growing phase, and it's a temporary growing phase, right? And your body is trying to cope quickly every single week to this small, minute change. And your body is just shifting to handle that in actually a great way. Most of the time, it's awesome that we're able to do that intuitively, but sometimes it's just taking a toll on your body. So often I'll just say, trying not to lean back so much and kind of arching your back or kind of slumping in this position, and instead trying to, hold yourself up in a way that you're actually using your muscles, but not like hanging on your muscles, if that makes sense, can be a way to just be conscious of, where am I holding my body in space? Like, why does it hurt for me to do that? And maybe just shifting and like figuring that out can be like one step. And I know that's general, but I think the question's also,
I mean, it's tricky when you're not able to see somebody. So thank you so much. And, as people who are here, we have another question. I have two more questions and then we'll let everybody go. As people need very specifics, and that's really the reason to reach out, right? So somebody here is asking, how do you know if they have symphysis pubis dysfunction, SPD, during pregnancy? They're 28 weeks feeling pain when walking and in the inner thighs. And then I have one more question for you about pregnancy pain after some issues after sex. So I would love to get to both of those, and then we'll let
Yeah.
everybody know. Yeah.
Sure. Okay. I'm going to try to do these both quick as possible. So, how do you know if you have symphysis pubis dysfunction during pregnancy? 28 weeks feeling pain when walking and in inner thighs. So it's a very just a localized. It's diagnosed just very simply with the location of the pain usually, and with exactly what you said, which is when moving. When you're moving your body, it's usually happening most of the time. Pubic symphysis dysfunction doesn't happen. The pain is not the worst when you're just sitting and doing nothing. It's when you're moving, because these bones are connected to your hips, right? So when you're walking, right, this bone is making you go this way, this way, this way, this way, right? So this is moving during that time. That moving is what creates that clinking and that kind of pressure on one side of the other. It can also cause some radiating pain down here, like sort of on the outside of the labia off to the side here and going down diagonally oftentimes, because you can see how this bone, this pubic bone, is actually larger than we think it is. So this whole, that there might be tenderness that's coming along here. You're absolutely right. There could be inner thigh pain. All of those things are indications. But a proper diagnosis obviously is best. Those are all definitely signs that you have it, but to be properly diagnosed, I would just make sure that you see. Oftentimes I get referred a lot of pubic symphysis dysfunction from GYNs. They're actually really great at detecting, or OBs to be like, I see that there's a lot of tenderness here. So you can see a physical therapist to help with that one.
Awesome. Thank you. And the last question would be, during my pregnancy after sex, I have low belly, pelvic discomfort for a couple of days, almost as if the baby's sitting very low, pressing on my bladder / colon nonstop. Is that normal, or can you address that?
Okay.
Thank you so much for giving us that question, because I know it's a lot to share out in the world.
Yeah, absolutely. Yeah, thank you for that. So lower belly and pelvic discomfort, as if the baby is sitting very low and pressing. So this sounds to me like there's some pelvic pressure that's happening. And there could be, and I'm just like trying to think that there could be two reasons for that, but probably more than that. But two of the reasons could be when you're, and just to clarify, this is with a male and female anatomy. I'm going to talk about with the sex. So intercourse with a penis coming inside. So if you can see, it has to penetrate through all of these pelvic floor muscles, right? And the bladder sits right behind the pubic bone. Sorry, a little bit higher, not directly behind, but it sits like up here in this area. So if you're experiencing like there's pressure or pain there, it could be the positioning and the new positioning. This patient is postpartum, right? During my pregnancy, after sex.
No,
okay, so whether you're pregnant or postpartum,
very low. I think during pregnancy. Yeah.
Okay, so whether pregnant or postpartum, you're, like we talked about, your bones are shifting, the alignment is shifting, the location of the organs are shifting. The organs might be descending a little bit because the baby is right on top. So because during penetration, it could simply be that everything just is, there's a lot of pressure. So there's weight that's coming down this way, and then you're pressing something this way, and then here is just being compressed and tight. That could be one reason that could be happening. The other thing that I could sense is that this is actually coming lower than we want it to. That's like in a way that's beyond what might be considered quote unquote normal descent. And we might be even lower because of the integrity of the pelvic floor muscles and the structures. So there might be some weakness that's there. Things might be a little lower than we want them to be. And I say all of that also knowing that your anatomy is so different from everybody else's. So it all completely just is dependent on how your body is structured. And then that could be causing pain and pressure downward also. So that does not mean code word for pelvic organ prolapse. That's just code for there might be a different or increased pressure downward. And so again, not a scary thing, but something that's very easily treatable or something that might pass. And that's the best case scenario.
All right. Well, thank you so much for coming out. I'm just going to launch this poll for people because we always ask, what else you guys want to learn. This helps us keep bringing you good content and interesting content. And, I wanted to thank you for coming out today and teaching us and sharing all of this knowledge with us. Everybody out here, I hope, this was helpful. Let us know if you have anything more you want to know, we'll definitely be addressing the pelvic floor a lot more now that we're able to bring pelvic floor therapy onto the Boober platform. You won't see it yet actually directly on the platform, but you can certainly request through and get connected to Sneha. So, and if people are in other, it sounds like you treat in 3 states, right?
Mm-hmm.
Whether it's virtually or not. So if you're not in these 3 state area, which remind me, which 3 states?
So New York, New Jersey, and Maryland. I'm licensed to treat you in those locations, but anybody who has a question or needs to be directed to a PT in their own state, reach out to me. Don't feel like you can't talk to me if you don't live in those states.
And yeah, feel free to put in a question for us. We are always happy to try and connect to you wherever you are. And also we are going to be bringing on other pelvic floor therapists who serve different states. So do reach out to us. Thank you so much for taking the poll. Lots of you want to take preparation for postpartum, I see, childbirth pain coping techniques, and CPR. So we offer all of those classes at Boober. So please join us. Come take my prep for postpartum class where we'll talk more about kind of getting ready for all of this. And we do have some great pain coping classes, so, and thank you everybody. I'm so glad that you enjoyed this.
All right. Thank you everyone. My pleasure. So great to hear all your questions.
Yeah. See you all soon. Thanks, Sneha. See you soon. Bye.
Bye-bye.